My name is Anju Relan, and I'm the Director of the Instructional Design and Technology Unit at the David Geffen School of Medicine. I am delighted to present this webinar today. A few words about the webinar series. It was initiated by Dr. Luann Wilkerson. She was the ex-Senior Associate Dean of Medical Education at the School of Medicine. She is now at University of Texas at Austin. Unfortunately, she has left us. But if you would like to pick up on her webinars that she delivered, there are 2 of them available on the website where you signed up. Facilitating small group discussions to promote learning and coaching for performance improvement. Both are, of course, excellent. And I also wanted to acknowledge Dr. Kim Crooks, who is the Director of Faculty Development, and she is the one who is funding these webinars. So a big thank you to her. I'm getting a lot of help from my assistant and programmer, Jason Rock, and I'm grateful for that as well. So as far as the instructions for the webinar participation go, you will be asked to participate via written or oral interaction intermittently. So occasionally I will ask you questions, and I welcome your comments throughout the webinar so that I can see where you are in learning or understanding, or just, if you have any questions about it. So welcome again. I wanted to, since most of the people who have signed up are School of Medicine faculty, I wanted to make everyone aware of a resource that they have available for development of materials with technology. It's called the Instructional Design and Technology Unit, which I head up. And it seeks to optimize the learning experiences of School of Medicine medical trainees by supporting faculty in the delivery of curricula via creative and evidence-based use of innovative technologies to enhance learning. So we are here to help you innovate and enhance teaching and learning experiences with technologies. Our team is represented below. We have a wonderful set of skills represented here. We have multimedia programmers, developers, and people who have done amazing work in the past. So a few points about what we actually do. We support the learning management, assessment, curriculum management, and clinical education systems. We develop original standalone applications and tools, which include video, multimedia, interactive modules. And some of these are done from a very original idea. So you just come with an idea and we take it from there all the way up to completion of the project, as well as evaluation and research. I also co-direct a 2-year medical education fellowship program at the School of Medicine. And in fact, we are recruiting the fellows in a couple of months. So if you are interested in developing your leadership skills and teaching and research skills, this is a program for you to apply for. For more details, please email me and I will send you the information. So let me orient you to the resources that that are available. These are documents and handouts that are available right now live if you want to download them, but they were also emailed to you yesterday. So I have included selected literature on technology enhanced learning, which is a mix of theory, practice, and research. It includes really wonderful topics like deliberate practice, theory of multimedia learning, theory of flipped classroom, and an excellent article on evaluation of technology. Not all of these will be covered in this webinar. This is really a very general overview. So if you want to really examine and investigate more deeply, please look at this list. I want to emphasize that technology-enhanced learning is all about using an evidence-based approach. So that's the reason for including these articles in the webinar itself. I've also included webinar resources in the form of websites and online materials. These are for faculty as well as popular sites that students visit. And we can take a look at those, some of which we will be actually examining in the webinar today. But we will not be able to look at everything. So please go through these websites and see what is applicable to you. Examples of these are Khan's Academy, iMedical Apps, which always has a very good up-to-date review of the latest apps in mobile technologies. A free software, Poll Everywhere, which allows you to substitute clickers on the spot. So with this, we will begin the actual webinar itself. I just also wanted to mention that since most of you are not able to see who else is participating, most people who have signed up are School of Medicine faculty. And I'm excited that I have access to them so we can discuss some of the topics which are very relevant today. Anytime that you feel you have a question or you want to share something with others, please feel free to write it down in the space that's provided in your interface. Please use the IDTU brochure, and also there is a handout on the UCLA Online Learning Initiative. It's a grant proposal which is due on March 1st. Please feel free to review it, and if you need help, we are here to help you with proposal development. So let's begin with the webinar. There is an explosion of technologies. I think everyone is immersed in their very own personal technology, especially called the iPhone, and I have to compete with the iPhone for attention, even with my kids. So there is a plethora of technology. You can call it an explosion of technologies. But what is it that we want to do with these technologies? And what is the value of having this surplus tools everywhere? So what we want to do today is, what I would like to do today is describe some strategies for selecting technologies to enhance student learning outcomes. So I want to focus on some very simple ways of in examining what is it that you want to do besides just getting swayed and by the allure of technologies. I want to present some practical guidelines for leveraging the technologies we've just seen. And I'd like to exemplify all the discussion with some projects that we have developed at IDTU, as well as projects which you can find online. So you'll just have a very good sampling of what's out there and how it fits into our overall objectives of teaching and learning with technology. So how does one actually get started with teaching and learning with technology? Very often, people are really taken in by what's the new kid on the block. So for example, Google Glass is really in and I want to use it in my class. How do I do that? Or can you help me implement a flipped classroom? And the buzzword is so strong and so ubiquitous that one doesn't even care to think about what is it that you really want to do with flipping your classroom. So I usually question faculty who come with this approach, calling it the bandwagon approach. Because everyone is doing it, I want to be a part of it. I have not completely ruled it out as something that should not be done, because if you have peers who are extremely successful with a flipped classroom and you want to come and say, could you help me implement a flipped classroom, which I've seen is extremely successful, I would completely support that. But without carefully examining the questions that you want to come with, without going through the problem identification process, it becomes difficult to come up with an appropriate selection of technology, as well as a design and development of that particular technology that you have in mind. So let's begin with a mock clerkship, fictitious clerkship, which I've called the case of a marginal clerkship. And let's see what's happening within this clerkship, and perhaps you can identify with some of it, because some of the comments here are, can be found in any clerkship, even some of the best ones. And let's see whether the student evaluations of this clerkship tell us anything about how we can strengthen and improve this clerkship using technologies. So here is a comment, and most of these comments are real comments which I have modified to preserve anonymity. So it's not as if these are completely out of the realm of possibility. So here's a comment: lectures were just PowerPoint droning. I could review these on my own. However, some lectures were useful because material was difficult. I had to decide which ones to attend or skip. So this is one comment. Please keep these in mind as we go through these 4 comments. Some of the procedures were difficult to learn because we had to strain to observe. I went online and searched videos on YouTube, but was never sure if I was watching the right video. The third comment is, I felt lost answering questions related to organ systems and physiology at the bedside because it was such a long time ago that I learned this material. Besides, do we really need to know? And lastly, overall, a frustrating experience. The interns and residents were often so busy that they hardly ever took the time to show us anything. I can say that most of what I learned was from my peers. So we are going to analyze the clerkship in terms of these 4 comments. And I'm going to pose this question to you. Given the nature and the quality of the comments, what do you think? Is technology is the answer? If you could please write your reflections down. I can read them out to others as they come up. Does everyone have a way of answering the question? I hope everyone's found a text field to answer this question. Is technology the answer to this infusion of technologies, I should say, the answer to this marginal clerkship? I'm still waiting, but I haven't heard from anyone. So I have one response. It could help or hurt depending on how it is used. Don't want to teach how to be distracted when you speak with patients. Right, okay. Any other question? Any other response? I completely agree with the first part. It could help or hurt depending on how it is used. Anyone else? Okay, we will move on. Thank you for answering, Gordon. But as you can see, the question here is much larger than somebody saying, here's one. I have another question, another response. Patients complain a lot about how doctors are always looking at the computer screen. That is so right. So, how do we teach students to use technologies in a judicious way at point of care? That's a very good point. So, I think what Gordon is referring to is what I have on the screen right now. I think what we've seen from these comments is that technology cannot be a fix. It is actually embedded in a learning environment. So if if students have access to knowledge at point of care, but they are not being able to use it in a learning environment, such as clinical education, next to a patient when they should be looking at the patient more rather than looking at the computer screen, then that particular technology has not served its purpose. So along with looking at different technologies, we also need to look at which kind of learning environment are we embedding this particular technology. And if we assume that this is indeed true, then the selection, application, evaluation, everything changes once we hold this assumption to be true. I will come back to the learning environment a little bit later in the presentation as well, but I'd like you to just think about this for a moment. What is it in your learning environment that facilitates or inhibits and stymies the use of technology for learning purposes? So let's assume now that you have identified a problem and you find that it actually could be resolved with some application of technology. How do we proceed from there? So what I have in mind always is to figure out what kind of learning is taking place with the question that has come up. So the problem that you're trying to solve with technology? What kind of a problem is it in terms of learning outcomes? And some of you may be familiar with Bloom's taxonomy, but Bloom was able to differentiate between different types of learning outcomes. And although there are dozens of taxonomies of knowledge, his is still the most widely used, accepted, and applied. So from this point of view, what we are saying is that a cognitive taxonomy is quite relevant for any problem that's related to knowledge. So if you want to build a fund of knowledge in histopathology, anatomy, pharmacology, and other subjects, which leads to expertise in clinical reasoning, then there are certain types of technologies which would be relevant to use. In this particular taxonomy, as you can see, it's a pyramid. So it starts with remembering. So lower order learning outcomes, which are quite different from upper level or higher order learning outcomes. And what we tend to do is we focus a lot on the lower, remembering and understanding, and we give less opportunities to students for applying, analyzing, evaluating, and creating. So this pyramid is also useful for us to understand where in the spectrum are we expecting learners to perform? What do we want them to do in order to learn the material that we have? So how do we use technology for improving knowledge? What we have done, and I'm giving you one example, we'll be going through several examples of technologies that we have developed, is an interactive histology module, lots and lots of, I shouldn't say one, there are dozens of interactive histology modules which are self-instructional. So students are expected to go through these modules the day before the actual lab session. And these are all, what you're seeing now is an example of something which is done with a very accessible technology called PowerPoint. And I want to emphasize here that one does not have to have extremely sophisticated, expensive, complex tools to be able to create effective software. The use of PowerPoint is very underdeveloped. We simply just take it to a lecture hall and create sequential lecturing with it, but it has the power to do a lot more. Animations, it has multimedia capabilities, it has hyperlinking. So what we have done in this module is harness the power of PowerPoint to deliver the self-instructional modules, which are beautifully created with original drawings, and it's done by our anatomy department faculty as well as IDTU developers. So, for example, students look at this slide, and it allows you to show highlights which come up on the slide. This particular module, the histology self-instruction modules, are used in the context of team-based learning. So students are divided into teams when they have a lab session. And it has been an extremely effective way of enabling a team learning sessions. So what I also want to comment on here is that the technology that we are using in this particular case is enabling a method. It's not the technology itself which is accomplishing the learning objectives. It is enabling a method called team-based learning. So as long as one focuses on a powerful, effective method and uses technology in a subservient way to it to enable the method, the use of technology will be more effective and more powerful. And in exemplifying how some of the cognitive domain learning objectives are fulfilled, I also wanted to show you an excellent software developed by our faculty, Dr. Sally Krasny, who's emeritus faculty now. It's called Perceptual and Adaptive Learning Modules. And as you can see, hundreds of these images are presented to the students. Students can answer any one of them. If it's correct, they receive the green bar over here. And they receive this feedback called correct and answered in a particular amount of time. And they go on to the next question. The next question comes up. It shows that the student selected an incorrect answer, which is in red, and the correct one is highlighted in green. And the students move on to the next question. So this particular set of questions is related to dermatology. There are also questions related to radiology, where the students are asked to spatially identify the correct structures. And based on their response, they are given the feedback which is spatial in nature. So you actually get to see what if it was correct, and what was the response is presented in the slide itself. And again, the feedback is correct, or the amount of time that's taken. So this particular PALMS has been extremely successful. We now have PALMS in the following disciplines: dermatology, histopathology, thoracic radiologic anatomy, ultrasound, as well as EKGs. And it has a very specific theory and objective. The assumption here is that expertise is characterized by both accuracy and automaticity. So, when students go through hundreds of these images, they are being scored on how accurate they are, as well as how fast they can do it, how much of the automaticity that we see in an expert is inculcated in a novice. And the objective here is, can we reduce the time taken to achieve expertise via pattern recognition? What we are trying to do here is promote pattern recognition to achieve automaticity and accuracy. And there are essential features of PALMs. It consists of many related categories. Each category contains many instances. Both accuracy and response time are considered in scoring. An item is retired when accuracy and automaticity is achieved. So this is a very, as I said, Dr. Krasny has done extensive evaluations, and the effect sizes of learning among students who have learned this material in a traditional way versus those who have gone through PALMs has been quite phenomenal. So this is an example of very, very, very good use of technology to promote cognitive learning outcomes. Let's look at now some of the kinds of outcomes that were mentioned by the students, which relate more to values, motivations, and attitudes. Because it's not just about knowledge that we are training medical students. It's also about professionalism, how to show respect, how to listen to a patient patiently, and all the ACGME competencies also include this taxonomy. So Bloom had a taxonomy also for affective outcomes, which starts with receiving, responding, valuing, organizing, and internalizing. So this also goes in an upwardly direction, going from the bottom to the top. And I wanted to show you one video that we have developed in IDTU. In fact, Dr. Wilkerson was involved with that as well. It is a part of a series called Humanism Videos. How does one teach humanism? And this will exemplify how this particular use of technology is quite different from what we have done with in the past two examples. So let's look at this example right now.
There's a finite amount of time in the day where you have to get a certain number of things done in order to optimize patient care. And essentially it can turn into a task. Patients are not looked upon as patients. They are looked upon as patient A, B, C, room 1, room 2, diagnosis A, diagnosis B. The way the system has created itself, in order to get through the day and the amount of time, physicians become less and less conscious about the actual compassion and care that goes with all these interactions. It's more of getting the job done. I do feel that if we are aware of this exact problem day in and day out and are conscious of it, we can make a difference. I think patients need to realize that they're meeting you for the first time as a fellow human being, greeting them, getting to know them. I think it may take an extra minute or two, but it's well worth it. And I think I've practiced that more and more as I've matured as a physician. But when I walk into a room, I make eye contact. I try to touch them as I talk to them, and I say who I am. I present why I'm here, and I listen. How you doing?
Well, you know what? I'm not great. You know, I'm nervous. I'm scared.
Wow. We need to talk. Bring your back up. I want to sit and talk with you. So, Mr. Smith, you said you're scared. Tell me what's going on. It's very understandable that the morning of, you're scared, you're going through these things.
You know, I feel a little better.
I'm your surgeon. Everything's going to be okay. Now, I can't prove that its emotions are 100% related, but I firmly believe that patients' hope and outlook will improve their outcomes. My name is Vishad Nabili. I'm an associate professor and residency program director with the Department of Head and Neck Surgery here at UCLA.
So I hope you enjoyed this video. It is quite different from the cognitive examples that I showed you before, where you're really interacting with that program or system. Here we create a video, but we can use it in multiple ways. We can use it to in a classroom situation, small group situation, where students are shown the video and then asked to ask questions about it or discuss it in a group. And it is just a resource which is extremely flexible and can be used in many different learning environments. But what I wanted to highlight from this video was that effective affective outcomes are really quite well accomplished with a good video. In this case, it was produced by Jason, and along with the clinical faculty involved. But there are videos available from commercial outlets, from online. One can search, and we will look at those options as well. So the next level of Bloom's taxonomy is the psychomotor skills. We looked at cognitive, we looked at affective, and now we are looking at the psychomotor skills. So at a skill level, what are the different ways, what are the different stages of accomplishing a good skill level? For example, how is a surgeon being able to perform procedures at a level of expertise and automaticity that they have accomplished? So one begins with the process of naturalization, articulation, precision, manipulation, imitation. In fact, actually, it's listed in the other way here. So one begins with imitation and ends with naturalization, where it becomes completely internalized. So we will also look at some examples of how procedural skills can be enabled with the use of technology. But before we do that, I would like everyone I would like to go back to the questions that we had from the clerkship and just write down where in the Bloom's taxonomy, whether you're looking at cognitive, affective, or psychomotor, where do these questions or comments actually belong? So if you could write down number 1 and 2. So you could say 1 was either cognitive, affective, psychomotor, and number 2 was one of the 3. I would just like to get some sense of whether you have been able to conceptualize how the learning problems and identify them by Bloom's taxonomy. All right, lectures were just PowerPoint droning. I could review these on my own. So we are talking about what is going on with lectures and PowerPoint. It's all about knowledge. So we're really talking about cognitive learning outcome here. I felt lost answering questions related to organ systems and physiology at the bedside because it was a long time ago. So again, questions related to organ system and physiology, again, it's a very cognitive learning outcome. So both of these questions belong to the cognitive domain. And as we have seen some examples of what does it take to present cognitive domains effectively via technology, we saw 2 examples. One was the PALMS, perceptual and adaptive learning modules, and we also looked at a very elegantly produced PowerPoint presentation, self-instructional module on histopathology. So for both of these, it might be possible to look at how can we improve the lecture delivery, and we'll see some examples of that. And also, how can we improve knowledge availability at point of care? We will look at that as well. Some of the procedures were difficult to learn. So there is always this concern when you have procedures, when you have a busy faculty clinician trying to show several students at the same time a single procedure and then just move on. So it is a very procedural learning, which belongs to the psychomotor domain. And The interns and residents were often too busy that they hardly ever took the time to show us anything. So showing, demonstrating, it can mean many things, but here I would say that let's say it is the idea of professionalism. And so this would fall in the affective domain. So as long as you have identified what kind of a learning outcome you have and which learning taxonomy it belongs to, it is easier for you to select the technology based on that. And we will get into the selection process now. So at present, do you have any ideas about or any problem that you are grappling with which could possibly have a solution using a more wholesome and more well-designed use of technology? Are you thinking of, do you have anything in mind that you would like to share? But anyway, as you go through this presentation, think about issues that you have and how, up to this point, where do your problems lie in the spectrum of learning according to Bloom's taxonomies. So let's look at what is it that what kinds of technologies do we use for different kinds of learning outcomes. So for basic knowledge delivery, we have podcasting. We podcast all the lectures, for example, in the medical school. We also record podcasts in a self-instructional kind of way so that students can make use of it whenever they like. We have PowerPoint presentations, of course. We have interactive PowerPoint presentations of the kinds that you saw. There are self-assessments. Assessment drives learning, and assessment has become one of the chief ways of delivering instruction, in fact. And there are many different theories which represent assessments: deliberate practice, spaced practice, mixed practice. These are all extremely powerful theories which can be used to design self-assessments. There are outright online tutorials, and we will take a look at that as well. There are mobile learning tools and e-texts. And one example that we will look at is the surgical anatomy app developed by Dr. Robert Relan, who is the professor of anatomy, and he is also the associate director of IDTU. There are thousands now of 3D anatomy tutorials available online, which are just there for disseminating information, for remembering, understanding, and applying. And of course, when you look at multimedia production, you're looking at animations to explain physiological processes. We also have several modules that we've designed to teach physiology, such as synapse and others. I have let me see, I have some responses. Patients. So Gordon has said we teach a lot of endoscopic procedures. Having video of the procedures, lesions, techniques, etc. have been helpful. Need more. And thinking about using similar mechanisms to evaluate education. Okay, so Gordon has already moved on with technology and has some experience with it. And simulators have also been helpful, right? So I think we will have a separate webinar on simulations. What we are looking at now is really online and, at the most virtual patients for our presentation here. But yes, I agree, simulators are extremely, extremely helpful. So, I would also say, in terms of developing materials, that this particular aspect of development is probably the easiest in terms of faculty being able to take the initiative and accomplish this on their own, use resources on the web, etc. But when we move up on Bloom's taxonomy, now we are looking at analysis and a little bit of application as well, evaluation and creating new materials. So Here we're looking at online case studies, online problem-based learning. We've developed a module which assesses problem-based learning completely online. Online case studies, we actually subscribe to several of these for our clerkships. We have family medicine cases, radiology cases, and amazing cases in surgery called WISE MD, developed at New York University. So not all of this needs to be developed by you. You can also identify resources which are commercially available, and the School of Medicine funds them if we find it to be really useful and there's a good rationale for integrating these into a learning environment. The multimedia modules that we have developed are fairly sophisticated, and some of them, for example, a sepsis module developed by one of our developers in the unit is actually now a requirement for all the residencies. So it can be extremely powerful way of delivering the higher levels of Bloom's taxonomy. We will also look at some social media like YouTube. Can we use some of those resources and repurpose or restructure them in our teaching? Clickers have been very successful in promoting higher order learning. So you can have students answer questions in a group in a large lecture hall and come up with individual and group responses which allow for application and analysis, basically problem solving. And of course, self-assessments are always necessary for all the levels of cognitive achievement. So what are we doing, as I mentioned, to accommodate affective domain? We developed video cases, as you saw the case on compassion. We also developed online situational simulations, and these are delivered via a tool called Zaption. I just completely forgot to mention that here. But that tool allows you to present video with questions and answers. It allows you to assess it. It allows you to stop in between and take, assess students' learning as they go along in the video. It's a very powerful tool, and I highly recommend people using it. And of course, you can create a mix of multimedia, which includes everything: video, technologies, animations, text, etc. So affective domain is actually a somewhat more neglected component of technology. We focus a lot on cognitive part, but increasingly we are, as ACGME tightens the rules and changes competencies, EPAs are on the horizon, the affective component will become a lot more important in developing as a method for methods as well as for technologies. And finally, for psychomotor domains such as surgical skills, videos, animations, and again, mixed technologies are the best ways of promoting that. Of course, simulation is the ultimate technology for developing procedural skills, but in the absence of that, in between. So what we do is we are thinking about, for example, preceding simulation experience with an online learning experience, so that when students go into simulations, there is less time spent on explanations, knowledge, and basic maneuvering that is needed for the procedures. I would advise you to look at the WISE MD cases, which are available online. If you just type that in, you can see samples of that. They are quite amazing in achieving these the psychomotor or skill development, physical skill development learning objective. So with that, I just want to take a little break and have anybody ask questions so far. Do you have any questions that you would like to, or any comments or any observations that you would like to share so far? All right, we are in a very virtual environment, so it is somewhat difficult to identify people and ask questions directly. So we will just leave it at your comfort level here. So let's look at some more examples of some of the tools that we've developed and are powerful. One idea that I did want to discuss was the flipped classroom approach. It is being used extensively, and it is indeed an effective way of teaching and learning. You will find several articles that I've included on the flipped classroom approach in the readings. So what happened in the past was, or let's not call the 6 months ago the past. It's still the present. In a traditional classroom, as you can see here, the teachers transmit knowledge in the class. So the remembering, understanding, applying takes place in the class. And then students are given problems to solve independently, which involve analysis, evaluation at home. In a flipped approach, the order is reversed. So, applying, understanding, remembering happens independently, but application happens together in groups, in face-to-face situations. So, I want to show you an example of materials that we have developed for flipped classroom approach in surgery clerkship. So, we have a 30-minute podcast of conceptual content, including a self-assessment. This podcast is developed in our unit, and all the faculty who are delivering it come to our unit, and we use Adobe Presenter to develop this podcast. It's about 30 minutes long, and it has a couple of self-assessment questions. The following day, students go back to the didactic session in the clerkship, and they have a face-to-face discussion with problems. So only cases are discussed with the assumption that students already have the conceptual knowledge. It is done once a week, and we are conducting we have already implemented that in three consecutive rotations, and we are conducting an evaluation presently of this. So let's look at what does this look like. What is a podcast which is created specially for?
My name is Dr. Deanna Attai. I'm a breast surgeon, and today we'll be discussing palpable breast masses, breast cancer screening, high-risk lesions, and breast cancer. One problem with examining the breast is it does not feel like a fluffy cloud or a In fact, the breast is usually full of lumps and bumps, and I often tell patients it's more like a pomegranate surface or a bag of frozen peas. Due to the lumpiness, many patients and some physicians are not comfortable performing a breast exam. It's important to stress to the patient that.
So I'm going to stop here just to show you. Different podcasting programs and apps have different features. We selected this because it allows you to present all the content on the site in a text format, and you can also view it by slides. So it's much easier navigation through the podcast. And it also allows instructors to write some notes, and it has searching capabilities. So since we're running out of time a little bit, I'm not going to do a lot of this. I just want to show you how by clicking on different slides, you can get to different components of the video. So coming back to this, you saw an example of this. So students see this, and they complete a self-assessment. This is an example of it. It's fairly open-ended. We've also conducted flipped classroom approach in a radiology lecture where we converted one single lecture into a flipped classroom. So there were about, I think, 90 slides in the original lecture, which were reduced to by half or 1/3 actually, 12 new cases were developed because we divided the class into 12 teams and each team received a unique case to solve. The class was held as a lab and not as a lecture. And when we looked at student evaluations, they were significantly higher statistically than the similar classrooms, the similar lecture presented in the years before. To encapsulate what is involved in a flipped classroom, here are some guidelines. The advanced presentation should be about 10 to 12 minutes long, and it could be a PowerPoint podcast, video, any online content or assessment. The face-to-face sessions need to have some problem solving included, or that should be the focus of the face-to-face session, so that the students are actually applying their knowledge to problems. And a flipped classroom actually requires a lot of commitment by faculty to facilitate how to facilitate groups, how to create problems which are appropriate for the face-to-face session or cases, and overall how to monitor the session when it's going on. However, we are very much in favor, the school is very much in favor of changing, static lectures into dynamic flipped classroom approaches, and we would welcome your, initiative in doing this for your own specialty. I want to focus also on an app developed by Dr. Trelease, as I mentioned before, and it is available on Apple website as well as for Android platform. This is for learning by the bedside, and of course, as Gordon pointed out, one has to also look at the learning environment and use these apps and other resources which are available on the iPhone or mobile devices judiciously as one learns about the content. I would like you to look at the existing resources which are online. So you don't have to develop anything yourself, but you can use what is available to either present it directly, or you can have these as self-instructional resources for students. And one excellent one is the Khan Academy, which has a full section on health and medicine. And this, for example, this module can be used for learning, but it can also be used for a flipped classroom approach where students can go through this or learn content via the Khan Academy. So there's some mixed findings about what is going on with social media like YouTube. So some researchers, this particular article, the researchers felt that only 22 out of 3,350 videos on auscultation cardiac auscultation were even worth considering for evaluation. And faculty need to spend a lot of time to curate the resources that students are seeing online. But in this particular study, the researchers felt that there was an advantage of placing the videos on YouTube. So I don't know how much time do we have. We are on till 5:15, so I would like to just quickly show you this video, which is just excellent. So this is a video on radiology. These are YouTube videos on radiology, which are created by a Stanford faculty member. And you can see how well these are done.
This is the fourth video in the series on how to interpret a chest x-ray, and the topic is the airways, bones, and soft tissues. The learning objectives are to be able to assess those structures on X-ray and to know the common etiologies of abnormalities seen in them. Let's start with the airways. On the chest X-ray, the airways can either be narrowed, deviated, or on occasion contain foreign objects. There isn't much to say about airway narrowing, other than the fact that subglottic airway narrowing is an important radiographic finding in croup and tracheal stenosis. Here's an example of a 3-year-old boy with several days of cough and fever. If we zoom in on the upper airway, you can see how the airway gets nearly pinched off near the very top of the film. This is sometimes referred to as the steeple sign because the airway ends up looking a bit like the steeple of a church. However, in my experience with adults, narrowing of the trachea is easy to overcall when they're asymptomatic due to overlying shadows from mediastinal structures. When it comes to airway deviation, deviation of the trachea is usually caused by unequal intrathoracic pressure between the left and the right sides. Let's look at an example. We'll start off with a normal chest X-ray and superimpose an outline of the airways, the heart, the lungs, and around the lungs, the pleura. What happens when air is introduced into the pleural space, a condition known as a pneumothorax? Since the intrapleural pressure is usually lower than atmospheric pressure, more and more air will begin to accumulate, and as it does so, the lung on that side becomes compressed. If air continues to accumulate, for example in a tension pneumothorax, eventually the intrapleural space becomes distended enough that not only does it further collapse the ipsilateral lung, it begins to push the heart, mediastinal structures, and the airway to the contralateral side, resulting in tracheal deviation away from the side of the pneumothorax. For another example, imagine a primary fibrotic process happening only in the left lung. Fibrosis leads to gradual contraction of the lung and reduced lung volume.
So as you can see, there are some excellent examples of cognitive and affective learning and procedural skills as well on YouTube. And students are, of course, extremely familiar with how to identify and find resources. So how do we interpret all of this? How do we make sense of all of this? What is suggested is that if we can curate these resources and point students to it, it will be far better than students identifying them on their own and not knowing whether it is what they're watching is accurate or not. So how does one begin? How moving on to production. So now you have identified a learning objective. You are ready to start this process of creating technology, some intervention with technology. How do you get started, and how do you actually produce it? First of all, look at existing resources. There's no point reinventing the wheel. There are professional societies which have resources. There are other medical schools which have made their online resources available. Your peers maybe actually have already invented that wheel. And there are commercial options. If you can afford, if the department is willing to subscribe, that would be the best way of, not recreating, 30 cases. It just takes so much more time to start everything from scratch. Do it yourself if you're familiar with the tools. And some of these tools are so easy to use. One is PowerPoint. If you can find ways of making your presentation interactive with PowerPoint, it can really come out to be a very elegant presentation. You can apply for a grant, and I've given you a handout. Online Learning Initiative is available right now if you want to take a look at it. And there are other grants available as well. Use the department technology resources or use the School of Medicine resources. And as you are producing the technologies, please remember that it's embedded in a learning environment. If your learning environment is not supportive, then any technology that you develop will not be able to work. So I have a comment here. The biggest concern is to ensure trainees use all this newfangled technology to enhance their medical education rather than replace their medical education. Some stuff you need to know right now as opposed to simply knowing where to look it up. I see this on rounds a lot more. Trainees become ignorant when their smartphone battery dies. Wow, that's a very powerful comment. And I really appreciate you letting us know about it. So there's always this tension about how much should students memorize and know rather than how much should they look up. And I think that tension will always remain given just the explosion of resources that are available. Students really feel that they don't need to know, but I agree that sometimes diagnostic reasoning, clinical reasoning can be affected by lack of knowledge. So it's up to us as faculty. Individual faculty also can have a say in how they want to introduce and integrate those resources in their own learning environment. But thank you for that comment. All right. So finally, I want to mention that one of the most important aspects of teaching and learning with technology is continuous evaluation. So evaluation is not just at the end. That's called summative evaluation. It has to be, as soon as you develop it, one-on-one evaluation takes place. What does a single student think of that product? Then you move on to a small group evaluation. What do 5 people think of that product? And then, of course, pilot it with the actual group. And continuously, evaluation is a continuous cycle of, assessing what's going on and improving upon the product. So what was done? Did it work? And at what cost? How and why did it work? How was it experienced? This is a webinar by itself, but I really want you to look at and read this article on evaluating technology-enhanced learning, a comprehensive framework. It is excellent. It really looks at many different models and comes up with consolidating all of those models into something which is cohesive and comprehensive. So it has been my pleasure to deliver this webinar, and unfortunately we couldn't have as much interaction as I wanted, but hopefully you have benefited a little bit from it, and you will get in touch with us if you have some ideas. Also, this webinar will be posted online where you registered for it. So if you have colleagues and others who might be interested in viewing this and other webinars, please let them know. And do think about teaching and learning with technologies. Thank you.